Good morning. My name is Monique Roobol. I work as a professor decision-making in urology at the Erasmus University in Rotterdam, the Netherlands. I am proud to present the work of the PRAISE-U consortium in Europe. What I'm about to tell you is all the result of an update of the cancer screening recommendations of the European Council, which was released in 2020. For the first time, prostate cancer screening was included within the recommendations to evaluate the feasibility and effectiveness of the implementation of organized programs. This all is part of a big plan, the European plan Europe Beating Cancer. And as you can see in this slide, the Action 21.1 is related to the three new screening entities: prostate cancer, lung cancer, and gastric cancer. PRAISE-U is an EAU, the European Urology Association-led consortium where the task is to investigate prostate cancer screening and how it could be implemented within Europe. It is a 3-year program which started in 2023, and it consists of 3 particular phases within the program. The first phase was in 2023 and 2024 to create a knowledge base. So we did research in all 27 EU member states to see what was needed to start a population-based screening program for prostate cancer, what was currently happening, and we did a detailed capacity assessment and developed a site-specific protocol for the targeted countries in which we were to run pilot studies. All this work that we have done is open and can be freely read and used at a dedicated website at euroweb.org. It is called the so-called Knowledge Hub. There you can find epidemiological data on prostate cancer screening facts per country, and an overview of all the barriers and facilitators, obviously, that exist to implement a population-based screening program for prostate cancer. This website is constantly being updated and is a true treasure for looking for epidemiological data on prostate cancer screening. The second year of our project is currently still ongoing and is all about actually doing pilot studies. And we have developed pilot studies in 5 sites within Europe. The aim of these 5 pilot studies is obviously to provide data on the implementation of a risk-stratified screening program. But what is most important is that we develop a program that fits into the national healthcare structure of the particular country, because this is the only way to success for a population-based program. Here you can see an overview of the active sites in which PRAISE-U is currently working. We have 5 implementation pilot sites located in Spain, which have 2 sites, in Ireland, in Poland, and there's one in Lithuania, which actually is the only country within Europe that already had a program that is now switched within PRAISE-U to a risk-based stratified program. In addition, we learn from countries that are a little bit more far advanced in implementing prostate cancer screening, which is Sweden and Estonia. So altogether, we have more than 7 sites in which we are actively working on prostate cancer screening. The general PRAISE-U algorithm is shown here, and as you can see, it is a risk-based program where we use the PSA test as a first risk stratification step. We do an additional reflex testing, which is open for all the countries to choose what they want to use here. There is a second risk stratification step after MRI, and obviously, because we are in an exploration phase, we spend a lot of time on collecting PROMs, we really want to learn within Europe how men are experiencing prostate cancer screening. Here you see then the result of the PRAISE-U algorithm, which is the basis, and actually how it is being filled in within the different pilot sites so that it fits into the national healthcare structure. You can see that there are different types of facilities. The method of invitation is according to what is used to be in the different countries. It can be by letter, by email, even by SMS is being used. And you see that the numbers of invitations is also depending on the resources and how it can be fit in at the moment. Same holds for the actual algorithm, where the basis is this risk stratified algorithm, but you can see here that the different countries implement it differently. The basis is the same, but the tests and the methods used are different. You can see that there is a difference in assessment of prostate volume. You can see that there is often used of the risk calculator, but certainly also of, for instance, PSA density as a risk stratification step. The MRI capacity and the machines are different, and also who is actually performing the biopsies. This is not a problem because we are running implementation pilot studies, and we are aiming to learn from all of these pilot studies. Here you can see the first data of the first men that are being invited and have accepted the invitation, which is all ongoing at the moment. So these are preliminary data. And you can see that all sites invite in the age range 50 to 69, and we can see a more or less similar age distribution. Marital state is impressive, it's very high. It is predominantly men that are married that actually are coming to these invitations, and the income is average or above averages. This is what we actually expect, and this is important material to study, certainly because we also want to read men in other circumstances. Here again, preliminary, I cannot stress this enough. These are data that are currently being collected, and it is an ongoing project. And here we see the distribution of the PSA groups, and remember the age distribution was more or less similar, which is reflected also in the PSA distribution, with approximately between 10 and 15% of men having a PSA of 3 or higher, and those are the men that need to be referred for further assessment, reflex testing. And here you can see that again, management based on the PSA, so the first risk stratification step and age. We know that we advise to stop screening in men at higher age above 60 with a very low PSA. And we said that approximately 10%, between 10 and 50% need further risk stratification as indicated in our program. Here you see the result of this first risk stratification step, and I've added a figure on the right side again to show where we are in the algorithm. So this is after initial PSA testing, but before a referral to MRI. Risk stratification can be done with the risk calculator PSA density, and here you see the result of those, and between 30 to 50% of the men, between 25 or 50% of the men need further assessment with MRI. So again, you see here that not all men with a PSA of 3 or higher need to be tested further. They can flow back into the algorithm, which is important if we are considering population-based screening and thinking about very large numbers of men. And this is a summary of the data we currently have. You can see that from the 1,000 men we tested, approximately between 100 and 150 are being referred for further testing because of an elevated PSA. We perform risk stratification in different ways. We learn from that, and we see that between 50 to 75 men are further risk stratified are further assessed for MRI. And then we do a second risk stratification step in those men with a Pirates 3 score, And our first preliminary data show that then there is again a diminishment in the number of men that need a biopsy. So in the end, from 1,000 men tested, approximately 35 to 50 men are actually biopsied, which is important if we again think about perhaps 1 million men that needs to undergo this population-based screening program. And this is actually in line with our Swedish partners who are already more advanced, have a lot of more data, including follow-up data, and where they applied the 4K score. And here you can see that we follow actually a similar reduction in the number of men undergoing detailed investigations. Then we are obviously now entering or are about to enter year 3, where we will start the evaluation of all the data we are gathering within PraisU. And we have developed prostate cancer specific key performance indicators, which we will use to evaluate all the programs and compare obviously with the existing programs and learn how prostate cancer screening can best be implemented within the different member states of Europe. But there's more going on than PraisU. As you can imagine, when the recommendation was released in 2022, this meant a major change in prostate cancer screening research. And now in Europe, we see a lot of additional pilot sites starting already their pilot studies or are expected to start their pilot studies. And we are aiming to bring all this data together in a big PraisU registry to learn how we can best tackle prostate cancer screening at the population level and develop a really effective program. And as you can see in the last slide, we have EU CanScreen, which is also a very large consortium, which is all about cancer screening. But within EU CanScreen, there is a specific task based developed for prostate cancer. And within this task, we are closely working with PraisU, and this all brings together many member states within Europe. And we have many prostate cancer screening pilots ongoing or about to start. So this is really exciting times actually in Europe. And if we then look at the map, who was actually, if we think 4 years ago, a little bit gray, it is now colored because of all the initiatives that are going on within the different member states, either through PraisU, either through EU CanScreen, or with still the very important randomized controlled trials for which we learn constantly, or through the OPT program in Sweden, which is already far advanced. So a lot of data will become available and we will learn a lot about prostate cancer screening within the national healthcare setting and really a population-based program. And thank you for listening to my presentation.